All right, hi everyone. Welcome to the second in our three-part webinar series that's going to show you how we can help capture additional revenue in your ED. In this session, we'll review and demonstrate our observation module. My name is Cindy Heisel, and in just a few moments, we'll be joined by our presenter, Steve Hendrix. Quickly, if you have any questions you'd like to submit for Q&A at the end of the webinar, just click on the icon with the question mark and type in your question at any point. We'll gather those questions and address as many as we can as time permits at the end of the session. If we don't get to your question, we'll follow up with you one-on-one. We will also provide a recorded version of this session to all attendees if you'd like to go back and review the material or if you'd like to share the presentation with a colleague unable to attend. Steve Hendrix is our host today. Steve is responsible for all operations and business development for T-Systems' RevCycle coding solutions, including coding operations and production, sales team management, and ongoing client relationships. And now to kick off our presentation, here is Steve Hendrix.
Thanks, Cindy, and welcome everyone. So we'll try to get through this very quickly. We've got 30 minutes allotted. I want to make sure we have time at the end for questions. The purpose today is really to talk about misinterpretations, misunderstandings regarding observation coding. And so we'll talk during this webinar about some of those misunderstandings and misinterpretations, try to bring some clarity to that. And then at the very end, we'll talk a little bit about our company, what we're doing around coding for observation stays, and maybe show you a little bit of our system at that time. But the real purpose is just to bring some clarity to this area. So observation is exactly what it says, and that is an opportunity to observe the patient further. And so we'll go through some of the requirements around that, but the real benefit of the observation stay is that, first of all, it frees inpatient beds. It allows us to further reduce any unreimbursed admissions that we might incur, reduce staffing costs for sure. You know, one thing that I will caution everyone is that as you're evaluating your facility E&M tool or algorithm, whatever you use to generate that facility E&M, what we find many times when we're visiting with clients and prospective clients is that their tool really undervalues the observation patient experience. There's a lot of resources that it takes to move that patient from the ED to an observation status, and so we would typically expect to see those assigned the highest levels of service. So that's just kind of a freebie there that I wanted to make sure and point out to everyone. So one of the first misconceptions is about observation itself. What is it? Well, it is really it's a status. Observation is a status. It's a level of care. What it is not is a location. So you can have a patient that has an observation status. They can be in a designated unit. They can be in the emergency department. They can be on a standard hospital floor. It's really the status that drives that observation patient. It's not a location. So that's really one of the first things that we hear asked when we go out and visit with folks, and just wanted to clarify that one. So given that we now have a patient that has an observation status, how do we determine that? Well, first of all, the reason that they're in observation must be reasonable and necessary. So that's the first thing for us to be able to code it as an observation stay. It requires 8 hours of service or longer, and the medical record must contain the physician order and the written request that the patient be moved to observation status, and for how long. So those things must be in the documentation in order for us as coders to code that chart appropriately. From the physician standpoint, we still need them to perform their standard history and physical. We need all that information, and we need them to periodically check in on the patient and provide an update, and then provide that discharge information. So those are some general coding guidelines that we must adhere to. What are some other coding and billing issues and errors that we see as we go out and do audits out in the field with our hospitals and with our prospective hospitals? Well, the first is that we find, amazingly enough, there's a lot of procedures, billable procedures, that aren't being captured. They're not being charged for. They're not being coded for. So that's the first thing that jumps out at us as we go out and do these audits. The second thing is the proper use of the designation or the admission code, the G0379. So that's the code that we need to assign to make sure that it's reimbursable by Medicaid, and we often find that it's not assigned when we go out and do our audits as well. And then really one of the bigger areas that we find where people struggle is that you have to view that observation stay as a single encounter. What does that mean? Well, it means if they start in the ED and are moved to an observation status, the coding and the rules around coding and the hierarchies around coding must be considered as a single encounter. So that becomes very important when you think about things that are hierarchical in nature, such as infusions or hydrations. So we have to know what was charged for in the ED in order to properly account for those during their observation stay. And we'll talk a little bit more about that as we move forward. Other coding and billing challenges that we see is one of the very specific rules that CMS has published says that when the patient is moved to an actively monitored procedure, and there's a list of them here on the screen, you must subtract those hours from the hours that you're charging for that observation stay. So if the patient's there for 16 hours, but 4 of those hours they're in one of these or multiple of these actively monitored procedures, then you need to subtract those 4 hours from the 16 observation hours and have a net observation charge of 12 hours. So that's another area that we find people really struggle is getting the hours right, having some kind of form or calculation that allows them to subtract out those actively monitored procedures. Then the final tip, and this is around the financial improvements that are gained by charging for those procedures and those hours in observation. So again, CMS states you should be applying outpatient charging rules and practices, so that's the first thing. And then the second thing, and this is the one that I mentioned earlier, and there's some documentation here to support that, is those injections, those infusions, those hydrations that have to be coordinated with what transpired in the ED need to all come together so that you get the right hierarchies and the claim goes out appropriately and is not denied by your payer. So those are some of the key gotchas that we see when we go out and we visit with our clients or prospective clients. So that's just a real quick kind of run through of some of the misunderstandings, misconceptions that we see when we're out in front of the hospital. So as a company, T-System RevCycle Plus, we provide solutions that address this. So in our outpatient charge management world, where we're accounting for the ED and observation, we have a technology platform that we'll show you here in just a second that helps us to get that right. And when we go out and do these audits, and I keep referring to these audits or assessments that we do, we find about $700 per patient in gross revenue that's being missed, either through the hours calculation or through the procedures, that is just revenue that the hospitals are missing out on. So there's really a tremendous financial gain to be had by getting this right. So we have a web-based coding platform. It's called our Advanced Coding System, and it helps either our coders or your coders get all of the pieces right. But I want to hone in on the observation module here. So the observation module has a calculator built into it. And the hours calculator helps us then manage those actively monitored procedures. So we put in the hours the patient's in observation. We put in when they go to an actively monitored procedure. It does the calculations, and it gets the right hours each and every time. The other nice thing about our observation module is it works hand in hand with our facility module that you see listed above, specifically our injection and infusion calculator. the calculator has all of the CPT-4 coding rules built into it. So it's a highly intelligent calculator that assures we're going to get the right code set each and every time. It assures we're going to get those hierarchies right. So think about now, we had the patient in ED, they go to observation status, we have a continuation of those infusions and hydrations. Now we have a technology that allows us to account for that entire encounter and make sure that we get the hierarchies right, we get those code sets right so that we get reimbursed. And then the other nice thing about our observation module is it allows us to allocate those charges out to each of the individual departments. So emergency department gets theirs, and then the unit department gets their charge allocation. So that's a real nice benefit of our observation module. And there's other components to our coding system, but this is the one that was most relevant for our conversation today. And just so you know, our coding module, our coding platform, can either be accessed by our coders in a full outsource arrangement, can also be accessed by your coders in a software as a service arrangement. So there's a number of ways to leverage our technology, and that's kind of the beauty of what we bring to the marketplace. And we can get into that with anybody separately outside of this call that wanted to kind of share that with you all. And then finally, I keep referring to the Auditor Assessment. If you have an interest in us coming out and doing an assessment of your ED and observation charging and coding process today, we'd be happy to do that. As part of attending today's webinar, there's no cost or obligation for that service. So again, if you're interested, you'll be given the proper channel to make that request when we're done today. So what I'd like to spend the last 7 to 10 minutes on is really to show you just a sneak peek of our observation module. And to do that, I've asked Jeannie Rue to join me today. Jeannie she heads up our auditing services, so all of our QA and audit team report up through Jeannie. So with that said, Jeannie, I'm going to have you come on over here, and I will bring up the demo, and it's all yours.
All right. So what I have showing on your screen right now is the observation module for an emergency department visit. And for our demo site, we've loaded it as 3 West Observation. As Steve mentioned, if you have floors that are indicated, we can actually load those for you. We'll also collect any of your attending providers that are there, and we can exclude that observation direct charge. So when the coder comes in, once they have the record in front of them or the encounter, they'll verify what date everything has started and what time their order is. So I'm going to go ahead and select my observation floor, which is 3 West. I have today's date in there, and I can say that it was at 1400 that I had the order, and that it stops tomorrow at 1300. Oops, let me go back here. At 1300. So as Steve mentioned, we have the exclusion hours here. So on this, the coder simply clicks Edit, and then we decide what our reason was. So if, let's say they went to the cath lab and they were there for 2 hours. I'm going to go ahead and select my minutes, click Continue, and hit Submit. And what it will do is calculate what my billing codes are per line of service here. So on 610, I have 10 hours. On 611, there's 11 hours. I actually had a total of 23, but here are my exclusion hours. So they can go ahead and be watching this as they're going through the chart. So the only chargeable units that are going to hit that claim will be the 21 units here. Any questions on that? No questions. Okay. All right. So as Steve mentioned, we're going to continue.
Okay, so what Jeannie's going to pull up here is our injection and infusion calculator. Again, the nice thing about the injection and infusion calculator is it allows us to capture all the injections, infusions, and hydrations for that particular patient. And if there's not a stop time recorded, it also allows us to capture the nurse of record, and so that we can generate a report that shows any nurse that didn't put a stop time in. So, Jeannie, you want to show that real quick?
Okay, so on the injection and infusion tab, they can select the department. So we have emergency department in 3 West. So if I started in the emergency department and I had a hydration without a stop time, I'm going to select that. I'm going to put in the start time of 8 o'clock, and then I'm going to put my name in here. And what this will do when I click submit is no charge will actually be generated because I don't have one, and that's why it's telling me you don't have any injections or infusions on this, so you need to tell us that. But this will generate a report that says, on 6/10, Jeannie Rue had 7 hydrations without a stop time. The APC impact of Jeannie missing that is 7 times $24.89, or we can actually put in what you charge for that. So that you can get a running total of your kind of repeat offenders, if you will, so that education can be provided back to the nurses to explain how important it is that we actually have those stop times. So I'm going to actually change this back to a regular therapeutic hydration, and I'm going to go ahead and put a stop time in for it. And I'm going to click submit. And right now what's going to happen is it will calculate a 96360, which is how it should calculate based on the CPT hierarchy. But we know this person went to observation. So I'm going to select observation, and I'm actually going to assign a medication infusion with a stop time here. And I'm going to put tomorrow's date down, and I will put 8 o'clock to 9 o'clock again, and click submit. And this is where the split charge allocation comes into play. So right here, the hierarchy has to change because that hydration will be trumped by your medication infusion. So the first medication hour, 96365, is being assigned to 3 West observation on 6/11. That hydration that we had in the emergency department on 6/10 is now 96361. It's an additional hour. So we wouldn't ever send 2 firsts out as these are both in the same IV site. We can change based on sites. We can change substances so that we are ensuring that we have, if that medication infusion runs again at a later time during the day, we're still going to pick the same substance number, and the calculator will address those down here on which site is going to have the charges posted to it. At the end of the day, what happens on the ACS side is we will actually post these back to your billing system utilizing your charge codes with the appropriate unit so that this goes out on the bill the way that it should. Any questions on that?
If so, just go ahead and type those into the chat portion of your of the webinar.
IV pushes are loaded here, and again, we can do the same thing, 3 West observation or the ED department. And then additional procedures pertain to any injections, like immunizations that might be administered or IM injections that are done. So all of that can be added here by the coder with the appropriate modifier if that is necessary. And then obviously charging it to the appropriate area. The facility procedures that might take place during the observation stay will also be loaded for the coders to select. So if a LAC repair is done while the person happens to be upstairs in observation, any of your standard charge master items will be loaded here for the coder to go ahead and select. And then at the end of the day, they can go ahead and complete the chart and move on. So we have our common procedures loaded here. But then it's based on basically a CPT book where we can actually come out and expand out what codes might be there. And as you can see, we'll have the CPT code plus your charge code that will be posted back to your system. And they'll just add the units. We can also add the physician if that is something that you are interested in seeing.
All right, thanks, Jeannie. So again, if you do have any questions, please go ahead and submit them through the webinar. So in summary, and again, I'll give plenty of time here to answer some questions. In summary, observation is a status, it's not a location. From a coding and billing standpoint, we need to consider the fact that a patient that is transferred from another department, we have to code that as a single encounter. So that affects our ability to charge for hydrations and infusions appropriately. We need to be able to capture the hours that the patient's in that observation stay. We need to be able to subtract hours for actively monitored procedures. And T-System, through the RevCycle Plus group, has a technology solution with related services that can address your observation challenges and help you, capture that reimbursable revenue and do it compliantly and accurately. So with that said, Cindy, do we have any questions?
We do have a couple. The first one is backing up towards the beginning of the webinar. We had someone ask, why do you feel that most hospitals struggle to correctly charge for observation patients?
Yeah, I think what we find most of the time, it's not a lack of desire, it's really a lack of technology capability. When that patient moves from the ED to observation, you know, they certainly are still getting care, obviously, but the systems in place or the technology in place just doesn't allow that knowledge transfer of what happened in the ED to observation. So a lot of places, when we ask them, they go, well, we don't really have a good way to do it, so we just don't do it. Or they'll charge the hours and not the procedures, especially injections, infusions, and hydrations, for that simple reason. They just don't have a good way to account for what transpired during the ED portion of that visit.
All right, next up, how does the data get sent to and from the solution into our host system?
Yeah, great question. So we work with our hospital clients during implementation to establish those data integration points. It can be as sophisticated as an HL7 interface, and it can be several options that are not as sophisticated as that. Flat file transfer, scripting tools. We have a number of ways to address that, but the preferred method is HL7.
All right, one more. Does the solution apply carve-out rules to all payers or only Medicare?
We can do by payer. We have that capability in our system to set up specific rules for specific payers.
One more. Is the observation module available both for full service or software service? I believe they're saying for software as a service models.
Absolutely. It's available under both service models, and we have clients using it in both fashions. So great questions. And Cindy, I think that's it.
Yep, I think that wraps it up. Thank you, everyone, for attending today's session. This will conclude our webinar. We will send out the recording. If you have any follow-up questions, please feel free to reply to that email. And on behalf of all of us, thank you for joining.